Good morning. Uh, this is going to be video number 3 for our pharmacology review. This is going to cover chapters 5 and 6, and probably some of the analgesic case study. So chapter 5.1 is the review of the nervous system and pain. Then we're going to go into 5.2, which is classification of non-opioid analgesics. Then we're going to go um, into what that's going to include salicylates, NSAIDs, and acetaminophen. So that's going to include 5.3, 5.4, and 5.5 all in one right there. And then after that, we're going to finish with chapter 6, which is the classification of opioids, the opioid mechanisms, usage, adverse reactions, along with the specific opioids used in their dentistry, the Opioids Inc. documentary, and the analgesic case study. All right, so let's start from the top. Okay, 5.1. All right, let's go. So we're going to review the nervous system and pain. Now let's start with the original video lecture Q&A. The answer for the first question is that capsaicin, which is released by chilies, is not released by damaged cells to stimulate the nociceptors. All right, we'll find out what is released as we go forward, but capsaicin is not released by damaged cells to stimulate the nociceptor. Also, CGRP stands for calcitonin gene-related peptide. Great. Now let's talk about pain. So what is pain? Pain is an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage. It can be complex and subjective, which is why it's a challenge to define. It can also be a symptom of an underlying condition. So there's temporal pain, which there are two types. There is acute and chronic. So acute meaning like something that hurts right away, something's the cause of this. Chronic is something happening over a long term. Okay. Then there's physiological pain. Okay. Physiological pain is also physical pain. All right. So that involves the peripheral, the somatic. So that's going to be something that is sharp and well localized. Okay. These inflammatory mediators are released when there's peripheral pain. Okay. Including with peripheral pain, you have peripheral sensitization, which is the normal process and enables effective healing. There are two types of peripheral sensitization, which is primary and secondary. Primary peripheral sensitization means that it's at the site of injury. Secondary peripheral sensitization is around the site of injury, okay? So more precise of what's happening is primary, secondary is somewhere around the site, okay? Then the other physiological effect, other than peripheral, would be visceral. That one is poorly localized, and it's also defined by aches, all right? So you have two types of pain, temporal and physiological. Then you have, and with temporal, there's acute and chronic, and with physiological, there's peripheral and visceral, okay? And peripheral has primary and secondary, which involves peripheral sensitization, and then visceral is ache and poorly localized. Let's talk about nociception, which leads on to nociceptors, okay? But first, nociception is the process of noxious transmission. Not all or nothing, and it's not all or nothing, and has a minimum threshold before an action potential is released. So it is related more closely to acute pain performed by nociceptors, all right? And the fibers or the fibers that are stimulated or the inflammatory mediators that are released for fast peripheral sensitization are 6, which include prostaglandins, histamine, ATP, bradykinin, 5-HT, and hydrogen plus ions. Then there's slow peripheral sensitization, and that's going to involve substance P, CGRP, calcitonin gene-related peptide, in the dorsal root ganglia and transports them to the periphery. And then substance P stimulates mast cell degranulation, vasodilation, and further sensitization. And then calcitonin gene receptor peptide is a potent vasodilator that allows for leukocytes and the immunoglobulin responses. So real quick, for nociception is a process of the noxious transmission, which is how we perceive pain. And we perceive it fast or slow. And if we perceive it fast, it's going to be prostaglandins, histamine, ATP, bradykinin, 5-HT, and hydrogen ions. If it's slow, it's going to be substance P and calcitonin gene related peptide. Okay, remember those. Now let's talk about the nociceptors. Okay, so nociceptors are free nerve endings specialized to cause depolarization when a harmful or damaging stimulant is present. They are found in the skin, the muscle, the bone, the tendons, the ligaments, and the viscera. Stimulation threshold can be reduced by a local inflammatory factor, which is called sensitization. Okay. Now, the brain does not have nociceptors, but the blood vessels within the brain do. And there are 3 types of nociceptors here. Okay, there's the thermal temperature, and there's mechanical, physical, and then there's chemical. So these 3 types of nociceptors are what help us tell our bodies that we're feeling pain. Okay, with thermal, we have a TRPV1, which explains why chilies are hot with capsaicin. Then there's the mechanical, which involves crushing, incisions, and breaking of the skin. And then there's chemical, which is the caustic or irritating molecules. Okay, we might come back to this just to elaborate a little further, just to get some more clarity. Let's move on to lecture 5.2 now. This is the classification of non-opioid analgesics, which involve salicylates, NSAIDs, and APAP, which is Tylenol or acetaminophen. This one's a big one here. So the first thing we're going to start with are salicylates. All right, this is derived from salicin, which is found in willow bark. Okay, so when we think of salicylates, there are a couple types of salicylates. Okay, there's the oral type, there's the topical types. All right, so ones that we ingest or ones that we place on our skin. The ones that they all involve salicylin. Okay, so let's begin with the oral types. The oral types, we're going to have aspirin. Aspirin is also referred to as ASA. It's the most popular and major member of the salicylates. All right, the medium dose of aspirin is 325 milligrams every 4 to 6 hours. And aspirin is an analgesic and an antipyretic. Okay. I also put anti-inflammatory on there. Yes, aspirin is also an anti-inflammatory. Okay, let's not get aspirin confused with APAP, as we will see later. Now, a low dose of aspirin or ASA is going to be 81 milligrams, which is a baby aspirin per day. And when the patient takes a low dose such as this, they are using it for antiplatelet effects and for prevention of a myocardial infarction and for coronary artery disease. The half-life of antiplatelets is 2 to 3 hours, when you take an aspirin. And this is, again, for the prevention of clots. It is irreversible, but new platelets form every 36 hours. Okay, so once you take it, it's going to prevent clots. There's going to be an antiplatelet effect, and then you have to wait 36 hours. Okay, but again, platelets are also refreshed every 4 to 7 days. Okay, now a large dose of aspirin is used for arthritis. The half-life for aspirin, I'm guessing in relation to aspirin arthritis, is 15 to 30 hours. Okay, and it is eliminated by zero order elimination, which we talked about before. I believe zero order elimination is the one that's more linear, that it's equal amount as time goes by. We'll review that again. Now, a large it is okay. Aspirin is absorbed in the stomach and the small intestines in 30 minutes. So in 30 minutes, you'll have peak absorption. Aspirin salicylates, they inhibit COX-1 and COX-2, which synthesize prostaglandins. Okay, so ultimately, by inhibiting COX-1 and COX-2, they're also inhibiting prostaglandins, and prostaglandins are part of the nociception. Remember, it's one of those things that causes to feel pain. So when it inhibits COX-1 and COX-2, it's inhibiting prostaglandins, and then that's what causes the analgesic effect. So aspirin, one thing we need to know about aspirin is that it increases stomach acid and it decreases the protective mucus barrier, which causes GI upset, such as nausea, vomiting, bleeding. It can also exacerbate ulceration. We will see that NSAIDs also do the same thing here. So upset stomach, though, is not an allergic response, okay? It's not an allergic response. An allergic response is when someone is experiencing like a type 1 anaphylaxis or hives or rashes or an asthmatic reaction. Usually that happens with acetaminophen and opioids together, okay? Not usually with aspirin. However, aspirin should not be combined with acetaminophen because that can cause renal damage. So again, aspirin should not be combined with APAP because it could cause liver damage. Another thing is that aspirin, you should not be using that if you're pregnant or nursing, since there is a slight positive correlation for birth defects. Aspirin is not good for children because it can cause Ray's syndrome, which is liver and brain damage. We'll see later that APAP has replaced aspirin when it comes to antipyretic effects for children. So for aspirin, we're not going to use it on children because it causes Ray's syndrome. Aspirin is more effective when it is given before pain. Also, taking less than 1 gram per day can worsen gout and interfere with gout meds. Now, the lethal dose of aspirin is 15 grams for a 150-pound person. And also salicism, which is an overdose of aspirin or ASA. The signs of that are tinnitus, hyperthermia, hyperventilation, respiratory alkalosis, headaches, nausea, vomiting, dizziness, and dimness of vision. Children are the primary victims, and they're going to require emesis and activated charcoal. I'm assuming emesis is vomiting. I hope that's correct. I will check. The other oral forms of salicylates, other than aspirin, is diflunisal and magnesium salicylate, which is Doan's Extra Strength. Now, for this one, for Doan's Extra Strength, this is a non-acetylated salicylate. There is no GI upset, and there is no antiplatelet effect with this one, and also it is contraindicated in patients with renal disease or cardiovascular disease. So you would not be taking magnesium salicylate, Doan's Extra Strength, as a baby aspirin. No, you wouldn't. And then there's also salicylate, which is another type of oral ASA. Now, the topical types of aspirin include methyl salicylate, which is usually found in Bengay or Icy Hot, which includes the oil of wintergreen. There's also trolamine salicylate, which is a cream. It's called Aspercream. And then there's also like the Neutrogena acne wash. So those things remove an outer layer of skin and can be used to treat warts. Okay, so that's for ASA aspirin. The next non-opioid analgesic that we're going to be talking about is non-steroidal anti-inflammatories, which are NSAIDs. Again, these things inhibit prostaglandins, okay, just like aspirin. Now, the different from aspirin in that it may cause sedation, dizziness, and confusion. There's also an increased risk for myocardial infarction, and it reduces the antihypertensive effects of ACE inhibitors and beta blockers. So this should tell us that if people have coronary heart disease, and they are taking like a baby aspirin or something like that, they should not be taking ibuprofen or NSAIDs. Okay, different from aspirin, like we'll find out later, like ibuprofen, okay, or naproxen. Okay. Another thing is that it's similar to aspirin in that the COX-1 and COX-2 inhibition happens with similar GI upsets and inhibitions of prostaglandin, which we talked about. Then we're going to go into types of NSAIDs that there are. Okay, there are propionic acid derivatives, then there's acetic acid derivatives, and then there is 4-aminophenols, which is acetaminophen. Okay, let's talk about the propionic acid derivatives of NSAIDs. Usually these end in profen. Ibuprofen, Motrin, or Advil, which those are the brand names for ibuprofen, is the gold standard for dental treatment. It is the oldest non-steroidal anti-inflammatory member, okay? The prescription of version of ibuprofen is going to be 400 milligrams to 800 milligrams taken every 6 to 8 hours. The over-the-counter amount is 200 to 400 milligrams every 6 to 8 hours. Okay, half-life is at 2 hours with 4 to 6 hours of duration, meaning that you will reach the peak absorption of ibuprofen between 1 and 2 hours. Okay, it is more effective than some opioids, such as codeine and or aspirin. Okay, now Celebrex is a type of ibuprofen or propionic acid, which is the only one that is a COX-2 inhibitor only, and it's used for arthritis. Okay. The other types are fluorbiprofen, naproxen, which is naproxen, and naproxen sodium, which is Aleve. For Aleve, naproxen sodium, that's taken 220 milligrams every 8 to 12 hours. It has a much longer half-life of 15 hours, and it is an 8 to 12 hour dosing schedule. Okay, so you'll take just 220 milligrams every 8 to 12 hours. And however, the peak is still at 1 to 2 hours, just like ibuprofen, even though it has a lot longer half-life. Now, there are acetic acid derivatives of ibuprofen NSAIDs, which are diclofenac, ketorolac, and etodolac. Okay, we're not going to get into that much, but then let's talk about the last one, uh, the last type of non-opioid analgesic. Let's talk about APAP. All right, acetaminophen, APAP, or Tylenol. Okay, Tylenol is the brand name. Acetaminophen is the generic name. And I want to be clear here. Acetaminophen is not a non-steroidal anti-inflammatory. Okay. It is the only drug in the market in the US for this category. The mechanism is unknown for acetaminophen or APAP. It's unknown, but the uniqueness allows for pairing with NSAIDs. Okay, so we could take Tylenol and ibuprofen, depending on the practitioner. However, it is all mainly acetaminophen is used as an analgesic and an antipyretic only. It's an antipyretic for children, okay, with no use, with children usage with no risk of Ray's syndrome, which is the liver or the brain damage that we talked about before. So children, if they're having fevers, they should be taking acetaminophen. Very important that we need to know about acetaminophen is that it affects the liver much more than the other ones that we spoke about. So, alcohol, barbiturates, medications for TB such as rifampin, and anticonvulsants such as phenytoin must be avoided when taking, if are considering or when taking, which you shouldn't be taking acetaminophen. It is toxic at high levels of, acetaminophen is toxic at high levels of 7.5 to 10 grams. Okay. Treatment of overdose of acetaminophen is going to need to require a stomach pump, activated charcoal, and the antidote, which is N-acetylcysteine. Okay, let's get into some more facts about things we need to know about APAP or acetaminophen. Is that if people do not drink alcohol at all, they can take up to 4 grams a day maximum. If people drink 3 drinks a day or less, they should not be taking more than 3 grams a day maximum. Now, if people drink 5 drinks or more, they should not be taking it at all. Okay? So no alcohol, 4 grams a day max. 3 drinks, 3 grams a day max. 5 drinks, don't take it at all. Okay, for APAP, it has a similar potency to aspirin. The regular strength is 325 megs, 2 tabs every 4 to 6 hours. Extra strength would be 500 to 650 milligrams, 2 tabs every 6 hours. And the peak concentration for acetaminophen is going to be between 1 and 3 hours, and it is absorbed in the gastrointestinal tract. Now the half-life for APAP is 1 to 4 hours, okay? Unlike ibuprofens, the other NSAIDs, since acetaminophen is not an NSAID, NSAIDs, remember, half-life is 1 to 2. All right, so that covers salicylates, NSAIDs, and acetaminophen, okay? It says here, after completion of this chapters, we should be able to classify the different types of non-opioid drugs, explain the mechanism of NSAIDs, relate aspirin dosages to its effects, explain how dosage of aspirin causes different effects in regards to blood clotting and uricosuric effects. We did list the adverse reactions of aspirins and other NSAIDs, including contraindications, allergic responses, the dosages of aspirin, the pharmacokinetics, the Tylenol, naproxen, all that stuff we talked about all that stuff, and the hepatotoxicity of APAP. Okay, now let's talk about opioids now. Okay, so opioids, talking about classification of opioids here. The origin of opium and opioids come from the dried latex from the capsule of the poppy plants. okay? Opioids are an agonist. They activate the opioid receptor, all right? So, but there's also antagonist and mixed agonist antagonists. Let's talk about the agonists first, which is the longer list, and which is going to be the list that has the high strength ones, okay? We're going to start with the high strength agonists, opioids first, all right? First one is going to be morphine. That's a high strength agonist opioid. The second one is going to be hydromorphone. That's a high strength agonist opioid. Then there's methadone, which is a high strength agonist opioid. Then let's continue with the intermediate strength of agonist opioids, which are oxycodone, ER. That's an intermediate agonist opioid. Also, oxycodone, by the way, oxycodone, ER. The other name for that is OxyContin. Hello, that should ring a bell for the documentary that's going to follow. We're going to talk about that. Then there's oxycodone without the ER. Then there's hydrocodone. These are low strength, okay? Hydrocodone, Vicodin, Loratal, Lorcet, those are low strength agonist opioids. Then, we forgot about meperidine. That's a high strength, okay? Then there's fentanyl, which I know that's a fucking high strength one. Another big cause of the opioid epidemic. Then there's hydrocodone ER and then morphine ER, okay? Those are all agonists, okay? Now there's antagonists, which is basically a reversal of an agonist. So if people are overdosing on an opioid agonist, such as fentanyl or morphine or meperidine, we can save their lives by introducing to them, and I think mostly intramuscular, just a side note, naloxone, nalmefene, or naltrexone. Naloxone is Narcan, nalmefene is Reverex, and naltrexone is Revia or Vivitrol. Then there's mixed opioids, which are agonist and antagonist together, which is weird. There's pentazocine, and that is an intermediate strength mixed opioid. And then there's also a partial agonist, which is buprenorphine, Buprenex. All right, let's make sure we know that, what are agonists, what are antagonists, and let's make sure we know these two mixed opioid ones that we just spoke about too. More importantly, the agonists. Let's talk about now the opioid mechanism of action, usage, and adverse reactions. Now, here we go. The brain and the spinal cord have opioid receptors that evolved from endorphins, which is endogenous morphins, okay? These are G protein coupled receptors that activate a cascade at the synapse, all right? The pharmacokinetics of opioids are that they are absorbed well via PO, which is an oral route, including insufflation, which is snorting, sublingually, and topical. It is opioids are metabolized by the liver within 4 to 6 hours and are bound to plasma proteins, which distributed through the body, and they are eliminated by glomerular filtration of metabolites and of unchanged drugs. Now, sedation is the most common side effect for opioids, okay? Then respiratory depression is second. When the pain is resolved or strength is too high, people feel euphoria. Now, that potentiates addiction and can also depress the cough center in the medulla, which is why codeine is added to some cough syrups. Opioids also cause constipation by decreasing gut motility and can be used to treat diarrhea. Okay, so if you're shitting like crazy, take an opioid, it'll stop it. Okay, let's get serious. 3 types of receptors, of opioid receptors, drugs. These receptors Okay, drugs have a different affinity to these different types of receptors, and practitioners use these different types of receptors to determine the ideal opioid for the person. All right, there's mu, there's delta, and there's kappa. All right, so mu, just like kappa, it's similar in some senses, but mu is used for supraspinal and spinal analgesia, sedation, meiosis. So it'll decrease the pupils down to 2 millimeters or less. This is a good identification for people who are on overdosing. Respiratory depression, euphoria, physical dependence, and constipation. So those are the mu receptors. Now, the delta receptors are usually like also for analgesia, which is most opioids are analgesics. Well, they are because they're stopping pain, right? But the delta receptor is going to cause more emotional and seizure type of effects. And then the kappa receptors are also supraspinal and spinal anesthesia, also sedation, also for meiosis. Now, the difference between mu and kappa is that the kappa receptor is going to cause more micturition, more urination, more excess urination, and more dysphoria, which is an uneasiness or anxiety. Okay, mu, kappa, delta, the two types of receptors. Mu and kappa are the most similar, the only difference being that kappa causes more urination, dysphoria, while mu causes respiratory depression, euphoria, and constipation. Okay. Delta is emotional and the seizures type. Now, let's talk about addiction to opioids. Okay. For addiction to opioids, there's a physical and psychological dependence. Okay. Increased doses require and usually take a few days, which is relevant to long term use. Okay. The strength of an analgesic effect is correlated with addiction potential. So the patient will need to taper off. Going cold turkey sometimes is not the right thing to do because it's going to cause runny nose, irritability, tremors, goosebumps, tear production, and yawning, and things like that. Addicts shop around for willing dentists and frequently cancel appointments to disappear from practice, or they claim low pain threshold, they claim allergies, or they claim that over the counter drugs don't work. Treatment for this includes methadone, since it has a very long half life, if I remember correctly. Now, let's talk about specific opioids used in dentistry. We're going to talk about morphine, oxycodone, oxymorphone, hydrocodone, benzohydrocodone, codeine, meperidine, hydromorphone, methadone, fentanyl, heroin, pentazocine, buprenorphine, tramadol, and tapentadol. Okay, so a lot of these are going to start to fall into Schedule 2 of the high strength. Okay, so let's talk about morphine. It is a Schedule 2 high strength drug. Okay, it's a prototypical opioid, and the potency of other opioids compared to 10 milligrams of morphine. So just 10 milligrams of morphine is called a morphine equivalent. Okay. Usually it's parenterally for postoperative pain, also oral for terminal illness. Okay. All right. Parenteral again means introduced into the intestines. So it could be IV. Anyways, moving on. Then there's oxycodone, which is also a Schedule 2, but is an intermediate strength. Oxycodone is the brand name, but I mean, it is the generic name, but the brand name of oxycodone is OxyContin. It is suitable for moderate to high pain, usually taken orally, PO, and used uh, for terminal or emergencies such as chronic cancer pain. It is oxycodone, Oxycontin is often combined with salicylates or APAP or aspirin or acetaminophen, such as Percocet, Percodan, and it's also monitoring of total APAP is necessary. Okay. Then we have oxymorphone. This is a Schedule 2 as well. It's a high strength. This metabolite, oxymorphone is a metabolite of oxycodone. It is parenteral in IR and ER orally. It's 3 times more potent than morphine. Wow, oxymorphone, holy crap. Used in cancer patients switching from oxycodone to ER morphine. Okay. Hydrocodone is a Schedule 2 low strength. Okay. Metabolized to hydromorphone. So hydrocodone is metabolized into a higher strength opioid. IR formulations are Lortab, only available with ibuprofen or APAP. ER versions also exist, Zohydro ER and Hysingula ER. It reduces abuse potential. Benzohydrocodone is also a Schedule 2 high strength. It is a prodrug that's converted to hydrocodone. Okay, so remember that. Remember we talked about prodrugs. It's 1.22 times as strong as a 10 milligrams of morphine. Wow, this is stronger than morphine. Now it's used for short-term management of pain, usually 14 days, only available with acetaminophen. That's benzohydrocodone. Okay, then we're going to go into codeine, which is a Schedule 2 as well. It's a low strength. It's the most commonly opioid used in dentistry. Okay, it's weak analgesic effects, but often is enough. Its prescription doses of NSAID may be used instead. So people should be taking NSAIDs before they go into codeine. This is interesting here. We should note that whenever we hear the term Tylenol 3, Tylenol 4, all that means is that it is acetaminophen with codeine. Okay, so Tylenol 3 is acetaminophen of 300 milligrams with codeine. Tylenol 4 is also 300 milligrams codeine. Here's the difference though. Tylenol 3 is 300 milligrams and it comes in a 30 milligram tablet. That's Tylenol 3. Then there's Tylenol 4, which comes in also a 300 milligram to 60 milligram tablet. To a 60 milligram tablet. All right. So it looks like Tylenol 3, which is codeine and APAP. You can get it in a smaller dose tablet, whereas Tylenol 4, the minimum dose tablet is 60. Okay. Let's talk about meperidine now. That's a Schedule 2 high strength, also known as Demerol, management of acute pain in the first 24 to 48 hours. It has a more rapid onset than morphine, but it is short acting. Drug interactions with MAOIs and phenothiazine. So maybe it should not be mixed with people who are taking those antipsychotics. Then there's hydromorphone, Schedule 2 high strength. I feel we spoke about this before. It's used for management of severe pain. It is more potent than morphine, okay? And it's an addict's favorite. So hydromorphone is an addict's favorite and it's more important. It's more potent than morphine. Use in dentistry for hydromorphone should be rare. Now, methadone, we talked about this. This is a Schedule 2 high strength. It's used for opioid withdrawal because it has a long half-life. There we go, of 15 to 55 hours, which makes it easier to withdraw from, but it's still addictive. It's used for chronic pain due to long dosing intervals, which is 8 to 12 hours. Respiratory depression and changes in heart rate are reported in people starting to take methadone. Okay, now let's talk about fentanyl. This is crazy. I was over here thinking that morphine was the strongest thing. Apparently, this Schedule 2 high-strength drug, fentanyl, is 100 times more potent than morphine. Holy crap. It is short-acting. It's used during and right after general anesthesia. It is available as a transdermal patch, which is replaced every 3 days, and it's used for terminally ill patients. It is one of the most abused opioids due to its strength and short action. So no wonder people are dying from fentanyl overdoses. Now let's talk about heroin. Heroin is a Schedule 1 drug, which is a high strength, but it's a high strength also. It's illegal and it's used recreationally. It often comes in powder, but it can also be injected. It's unpredictable and toxic because whenever it's manufactured, we don't know what they're cutting it with. Pentazocine is a Schedule 4. That's an intermediate strength. It's an agonist antagonist. It touches the kappa, delta, and mu. It's a kappa and delta agonist and a mu antagonist. It's similar effects as opioids, but it's a decreased risk of addiction due to less euphoria. All right. So that's pentazocine Schedule 4 agonist antagonist. Now let's talk about buprenorphine, which is a Schedule 3. It's Buprenix. It's a partial mu agonist. It suppresses withdrawal symptoms during sudden withdrawal. It can exacerbate withdrawal symptoms, and it has a low abuse potential due to partial agonism. Then we have tapentadol. Tell me why I feel this is going to be on the test. Tapentadol is a Schedule 2. All right. There's a high abuse potential there. It is an opioid receptor agonist. It's a norepinephrine reuptake inhibitor. It increases norepinephrine in the synapse. Its tapentadol is used to treat moderate to severe pain. Norepinephrine reuptake effects make it useful for neuropathic pain. So neuropathy, think tapentadol. Neuropathy, tapentadol. I feel that's going to be on the test. Now, MAOIs must be discontinued for 14 days prior to taking this drug for neuropathic pain. Okay, so those antipsychotics or psychological drugs such as MAOIs or tricyclics, mostly your MAOIs, discontinued for 14 days before you take tapentadol, which is a Schedule 2. Now let's talk about tramadol, which is a Schedule 4. Tramadol. Okay, tramadol is a mu agonist. It's a serotonin and a norepinephrine reuptake inhibitor. So it's an SNRI, and its effect alter the ascending spinal tract. Okay, it's a weak analgesic, and addiction is still possible. Similar withdrawal symptoms to other opioids, but SNRI effect will cause a black box warning for increased suicidal ideation. So tramadol will increase your suicide. And I just want to go back to this schedule stuff because I know we talked about this, and I want to just make sure I remember correctly that tramadol, since it's a Schedule 4, that means it's one of the PAMs. Yes, and Ultram. Yes. Even though there's less abuse potential, tramadol is Ultram. Yeah. Okay. So that's that. What else do we need to learn here? Dental use of opioids. Dentists are the fourth highest prescriber of opioids, 28.9%, 1 to 1.5 billion IR prescriptions. All right, Daniel, make sure you know that what IR and ER mean. Often prescribed due to NSAID intolerance or ineffectiveness, the quantity of tablets prescribed often more than needed. And acute usage of opioids has addiction potential. Usage of low-strength opioids is first recommended. The most potent opioids should be avoided unless absolutely necessary. Patients should be reminded that short-term use is unlikely to cause issues. All right, so dentists are the fourth highest prescribers. Chronic oral facial pain management. Pain may be treated with opioids, mouth or facial pain, but NSAIDs should be used first. If NSAIDs are ineffective, then the dentist can utilize opioids. Patients should be seen in the clinic and evaluated. Prescriptions should be small for the amount of drugs with no refills when dentists are prescribing opioids. Chronic pain often manifests differently from acute pain. For example, TMJ pain may be better treated with NSAIDs, muscle relaxants, and antidepressants. Interesting, antidepressants. So if people have TMJ pain, you shouldn't give them opioids. So that's the end of that. We're also going to just kind of go into really quick the Opioids Inc. documentary. Remember that this was a pharmaceutical company that was created by this crazy looking man who was pushing the sales of Oxycontin, and then he spiked the usage of fentanyl. Okay. Um, um, yes. The name of the company in that documentary was called Insys Therapeutics. Okay. Um, they profited so much from a fentanyl-based painkiller that is this again the strongest, one of the strongest opioids, and they bribed doctors and they committed insurance fraud. Okay, and it's just a pretty crazy story, you know. Um, Now let's see what else we need to talk about. We'll talk about the analgesia case study and some other thing, but just make sure you remember the details. All right, I gotta use the bathroom. Thank you so much.